Just to make this clear, definite diagnosis can only be made through brain autopsy. So after the subject dies, we get the brain, dissect it, examine it under the microscope, and we find the evidence for neurofibrillary tangles and the amyloid plaques. So what we can do while the person is still alive is a clinical possible or probable diagnosis that can be made, which depends on history, examination, neuropsych testing, and a lot of workup to confirm or exclude other possibilities for neurocognitive disorder. Some genetic testing can be helpful, like testing for the ApoE4 allele, and CAT scan, MRI with volumetric studies. The PET scan and SPECT scan may also guide diagnosis as radiological biomarkers. There are also some FDA-approved radiopharmaceutical agents that can be used in the PET scans for Alzheimer's disease. So the diagnosis per the DSM-5 is 3 possible diagnoses. Either you have an evidence of neurocognitive disorder with genetic evidence like the ApoE4 or the other genes that may cause the early onset Alzheimer's disease that makes a probable neurocognitive disorder due to Alzheimer's disease. If you have a neurocognitive disorder with a typical onset and course of illness from the history taking, plus at least 2 cognitive deficits, plus functional disability, and you are able to rule out all the other plausible causes of this deficit, then we're also talking about probable neurocognitive disorder due to Alzheimer's. The last possibility, if you have a decline in memory and learning alone with functional disability, no genetic evidence, and the course of illness is a little bit atypical, then it is a possible neurocognitive disorder due to Alzheimer's disease, and we should consider other causes as well. So, unlike what you may think that Alzheimer's disease is the most common cause of cognitive impairment, but it is still a diagnosis of exclusion. You must exhaust all other possible etiologies first, because the definite diagnosis of such a disease is by brain biopsy. And that's why we mentioned in the previous slide that even if you have an evidence of neurocognitive disorder, you either back it up with genetic evidence, back it up with a typical course and a functional deficit and excluding other possibilities. If you don't have these elements, then you downgrade your diagnosis from probable to possible. So here's a diagnostic approach that I suggest in clinical settings. You start with a history, and you must include a reliable informant, somebody who's living with the subject, somebody who knows him, especially pre and post symptoms. Physical exam, including vital signs. Neurological assessment, including speech and gait. Cognitive testing. Screening for depression, because it can be a reversible cause of neurocognitive impairment. Labs to rule out other possible causes like vitamin deficiencies, like toxicities, like drugs or illicit substances. These needs to be ruled out first. You need to do some brain imaging to confirm your diagnosis through radiological biomarkers and exclude other possibilities of the neurocognitive disorder you're dealing with. Some special tests may be indicated, depend on the diagnosis you're looking for, and you end at a probable diagnosis and a differential that may need revision as you start treatment. So what's the prognosis of Alzheimer's disease? Well, we're looking at a chronic progressive course despite all the efforts that we can make in a clinical setting. A third of the patients will show slow progression, the other third will show moderate progression, and the last third will show rapid progression and death within 5 years. Pneumonia and dehydration are usually the most common immediate causes of death. Survival is definitely affected by this disease. So at the diagnosis between age 60 and 70, the survival years are typically between 7 and 10 versus 15 to 23 for those who do not have the diagnosis. If the diagnosis was made at age 90, then we're looking at 3 more years of survival versus 4.5 years of survival. and men have a less favorable survival prognosis than women.